Welcome to episode 2 of a comprehensive review of dermatopathology. Today we're going to cover the Psoriasiform and Lichenoid reaction patterns. So first I just want to spend a minute to talk about what is a reaction pattern. There's two different ways, or actually several, but two main ways that people learn dermatopathology. You can either divide it up by the inflammation pattern, be it a perivascular superficial pattern or superficial and deep pattern, and then divide up the different tissue reactions, or you can divide it by tissue reactions primarily and then discuss, given whatever inflammation pattern is present, what do you find? That probably makes no sense to a lot of people, but as a dermatologist in training, because we learn things by tissue reaction patterns, things being lichenoid, psoriasiform, spongiotic, that's the way I like to teach dermatopathology. And then within those patterns, you may see different patterns of inflammation. So this tissue reaction is referring to the changes in the epidermis that results or are part of this inflammatory process. And the dermatitis refers to inflammation in the dermis. Paniculitis refers to inflammation in the fat. And so given these tissue reaction patterns, meaning the changes in this epidermis, then with the addition of the pattern of inflammation in the dermis or dermis and subcutis, then we have different differentials. So what do we mean by a psoriasiform pattern? Psoriasiform pattern is defined by epidermal hyperplasia with elongated, reedy, and irregular pattern. It does not necessarily mean psoriasis, but that is what it means. You have epidermal hyperplasia or thickening of the epidermis. And usually that's due to an increased mitotic activity. So it's causing your epidermis to grow. So psoriasis is kind of the classic disease process in this category. Pityriasis rubra pilaris is another, but chronic spongiotic dermatitis, lichen simplex chronicus, also fall in this category. ILVEN, which is inflammatory linear verrucous epidermal nevus, which kind of looks like psoriasis in a linear epidermal nevus pattern, shares these qualities, and nutritional deficiencies, infection, and mycosis fungoides can also have this pattern. So psoriasis is the prototype. What are we going to notice at low power that's going to bring us towards psoriasis? I like to rank order the findings in what's going to catch my eye to bring me to that diagnosis, and you can confirm with the other things on the list that might be, less sensitive or specific. So for me, the most sensitive feature of identifying psoriasis is noting this dry parakeratosis with neutrophils. What do I mean by dry? I mean there's no serum in the parakeratosis of the cornified layer, and there's sandwiched neutrophils in between. The scale tends to fly, which I'll point out later, and that just means that the scale tends to curve upward as opposed to curving downward with the epidermis. You lose your granular layer in advanced lesions. You won't lose it in early lesions. And then you have to note that in early and acral lesions, you can have a fair amount of spongiosis. And so that can make diagnosing it slightly more difficult. And then you have these dilated vessels in the tips of dermal papilla, which I know is one of the more sensitive features for other people who don't necessarily use the parakeratosis to notice it right away. So here's a picture of a mature psoriasis plaque where you see regular epidermal hyperplasia. This one's cut a little bit tangentially, so you see your superficial vessels, kind of your dermal papilla in the middle here. But generally you get the picture where you have regular acanthosis, all about the same length. Your reedy ridges are about equal in thickness. You have this scale. See, this is what I mean by flying scale, where it curves away, upward, or is flat, rather than in spongiotic dermatitis, you tend to see the parakeratosis hug the rounded surface of the epidermis more. And then going in, this is where you note, for me, the most sensitive feature of psoriasis, which is these dry neutrophils. You see the multi-lobed nuclei of your neutrophils with their pink cytoplasm sandwiched in this parakeratosis in the absence of any serum. Remember, the serum means that you had spongiosis and the fluid was squeezing out. So this dry parakeratosis with flying scale and neutrophils, for me, is psoriasis until proven otherwise. Then in a mature lesion, here you have your loss of your granular layer, you have thinned suprapapillary plates with blood vessels that are dilated, but this is the most sensitive feature. Here is an early lesion of psoriasis where you know that you do not have regular acanthosis. You do not have a loss of a granular layer, and your blood vessels are not necessarily that prominent up in the papilla. So what is your most sensitive feature? It is the parakeratosis that is flying here with neutrophils sandwiched inside in the absence of serum, your dry newts. Here again, so that was a picture of guttate psoriasis or early psoriasis. And then here's another picture of psoriasis. You have neutrophils sandwiched in your parakeratosis, a loss of the granular layer. Here's your dilated blood vessel. Here's from a little bit farther out. And you can note here, you do have a little bit of spongiosis. This is not an old lesion. You don't have regular acanthosis or psoriasiform epidermal hyperplasia yet, but you do have the parakeratosis with the neutrophils. Here's another example. This lesion is, you know, somewhere in the late stage of psoriasis, but you have this flying scale, and here's your neutrophils. Neutrophils disrupt this regular pattern of parakeratosis. So when you're looking far away, you see these pale little nuclei that are retained from your rapidly turning over epidermis. And then here you can see that color is disrupted. There's something smashed in there. Those are the nuclei of your neutrophils. Okay, here's some more over here. Flying scale, you do not have a loss of your granular layer here. Some people notice these blood vessels as a sign rather than this. Everyone sort of sees slides differently. Here's a nail. How do I know I'm looking at nail psoriasis? Well, the nail psoriasis looks like the cornified layer of the skin. You have dry neutrophils sandwiched in the cornified layer, which is essentially your nail plate in this instance. And if this is negative for PAS and there's no fungus, then it's probably psoriasis. Here's a very spongy lesion. It's not perfectly psoriasiform. It's sort of early. You might even be in close to an acral area or an elbow or a knee where you also can see a lot of spongiosis. But here the scale, again, is sort of flying with the neutrophils. And so that's still, for me, points me in the direction of psoriasis. You can even have a little bit of lichenoid change with scattered necrotic cells. So that's psoriasis. ILVEN stands for inflammatory linear verrucous epidermal nevus. The differential for this is linear psoriasis, but it looks different because it's in a tufted pattern. So what in the world do I mean by a tufted pattern? Well, here and here and here have different patterns. What you notice here is you see a loss of the granular layer, and then when we go up close, you're going to see parakeratosis with neutrophils. And that sort of reminds you of psoriasis. In between here, you have a section where you do not have parakeratosis, you do not have neutrophils, and you do not have a loss of a granular layer. To the side of this section, you also have a section that's spared with a retained granular layer and no parakeratosis. So these are the tufts. You have like psoriasis, not psoriasis, psoriasis, not psoriasis. It's not perfect psoriasis. It looks kind of like psoriasis, but it's not perfect. As we can see here, you have your neutrophils, loss of the granular layer, parakeratosis, but you also have bacteria, which we don't usually see bacteria sticking to psoriasis, right? With our Th1 inflammatory process, it's not common to see impetiginization of psoriasis. But regardless, for all intents and purposes, it looks like psoriasis and it's tufted. Those are the findings of ILVEN. Pityriasis rubropilaris looks almost like psoriasis, but it's not quite right. It's almost like a diagnosis of exclusion. So they describe this checkerboard pattern in the parakeratosis, and that's a very, abstract checkerboard, I want you to note. So when you go in, you're going to notice that there's skipping areas of ortho and parakeratosis. And it looks like psoriasis, except you go in and you cannot find the neutrophils in the parakeratosis. You retain your granular layer and you have a sparse infiltrate sometimes with some plasma cells. So from far away, this should make you think, oh, I might be looking at psoriasis. The scale kind of flies a little bit like psoriasis. And your granular layer is not super prominent, and you have fairly regular acanthosis of the epidermis. But when you go in, you're going to note that this parakeratosis, you see how it's present here, and then it's not present here, and then it's present here, and it's not present here, but it's present there. This is that skipping checkerboard pattern, which is not going to jump out at you, but if you look carefully, you will see it. And then we see, but also when you look very closely, you see no neutrophils in there. And then here is your granular layer that's retained, making it also not perfect for psoriasis. So, this has been described by some experts in the field as a diagnosis they have missed most commonly in their career. So you want to think about it. If you're reminded of psoriasis, you do not find these features, this is when you think of pityriasis, rubra pilaris. So here's another comparison. And really, it's the neutrophils and the blood vessels, except I'm just not a person that really looks at the blood vessels first when I distinguish between those indices. So lichen simplex chronicus. What does lichen simplex chronicus look like? It looks kind of like acral skin, but you have this hairy palm sign. There are hair follicles. You have compact orthokeratosis, hypergranulosis. That happens with the rubbing, epidermal hyperplasia, and you should have fibrosis. So the difference between, say, chronic spongiotic dermatitis and lichen simplex chronicus will be the amount of inflammation, the superficial perivascular infiltrate, in a dermatitis, which should be lacking in pure LSC, and the amount of fibrosis, which tells you that something's been manipulated. So this is a picture we saw in the last session, where we see this compact ortho, kind of like you see in acral skin, hypergranulosis. Here you can see it almost wedge-like. Regular acanthosis, that's psoriasiform epidermal hyperplasia, but here you see this fibrosis that trails around it. So it's not just a chronic spongiotic. You can tell that it's been rubbed because of that. And then depending on the amount of inflammation, you may decide, well, it's very inflamed, so there's probably an eczema that's been rubbed here, as opposed to it's just being rubbed and there's no longer an active dermatitis. And that threshold varies from dermatopathologist to dermatopathologist. Okay, up close. Here's another look. Looks like acral skin. You almost have lamina lucida, right? But you shouldn't have hair follicles. All right, so nutritional deficiency. This includes everything from pellagra, acrodermatitis enteropathica, necrolytic migratory erythema, necrolytic acral erythema. These will give you a psoriasiform pattern in the epidermal hyperplasia with confluent parakeratosis, and then you're going to have pallor in the upper epidermis. It kind of, if you think about it, it's as if you don't nourish your skin enough from the inside out, so the very outermost distal part is dying from lack of nutrition. Okay, so here's an example. This is like not a very good one, but you have a little bit of psoriasiform epidermal hyperplasia, and you have parakeratosis and just this death of the upper portion of the epidermis. See, it can either be pallor or death. The pallor is just indicating unhealthy keratinocytes. Here's another example. This one looks much more like psoriasis, where now you have confluent parakeratosis, even with these neutrophils up here, but then you have pallor of the upper third. And it can actually be very difficult to distinguish this from psoriasis. So a lot of clinical history and things like that will help. Because if you replicate your epidermis very quickly, you can get pallor also. All right. So chronic spongiotic dermatitis, we covered this in the spongiotic section, but you can have very, regular appearing psoriasiform epidermal hyperplasia with chronic spongiotic dermatitis. But look how the scale kind of hugs the top of the epidermis here. It's not flying. And you also have all these little areas of wet serum. You may have neutrophils. You certainly will have neutrophils if it's impetiginized, because infection brings neutrophils. But if it's wet, it is not psoriasis. So all of this amorphous pink material, that's the serum. And then you can see you have some neutrophils, but you probably also have Langerhans cells and other cells mixed in there. So this is, and then here you have a very thickened granular layer. Well, it's not thickened substantially, but it's not thinned, even though the epidermis is already very thick, meaning it's been going on a long time, okay? So here's the superficial perivascular inflammation, and then you probably, if you can look closely, you'll see eosinophils. That also suggests that this is more in the eczema family than the psoriasis family. Here's an up-close chronic sponge, wet scale versus a flying scale with dry neutrophils. Loss of granular layer, presence of granular layer. Sometimes you'll have combined patterns. So if you have psoriasiform epidermal hyperplasia and a lichenoid infiltrate, then you might think of this differential of mycosis fungoides, secondary syphilis, and pityriasis lichenoides. So this is mycosis fungoides, and you can see the psoriasiform epidermal hyperplasia is slightly unusual in that your reedy ridges are long and thin as opposed to being long and fat. And then you have this lichenoid infiltrate of these lymphocytes kind of, you know, obscuring your dermoepidermal junction, but they're obviously very big and large compared to these cells down here in the dermis. And we're going to talk a little bit more about invisible cancer when we get to part 2 of this series and talk about neoplasms. But for the number of lymphocytes up in the epidermis, we have remarkably little spongiosis and little damage to the DEJ for an interphase change, because these cancer cells are sort of invisible and they're just present in the epidermis. But this is a psoriasiform and lichenoid pattern. Here's an up close of these big, large, atypical appearing lymphocytes compared to these little normal lymphocytes in the dermis. Here is psoriasiform epidermal hyperplasia. I'm going to trace out your elongated reedy ridges here. And then you have, you know, occasional necrotic keratinocytes indicating that you have lichenoid inflammation, which we're going to cover in the next section of this episode. And when you have psoriasiform and lichenoid inflammation with some neutrophils and then a bunch of plasma cells that you can see here in this infiltrate, here's one, here's a bunch, then you think of secondary syphilis. And then here, which is another diagnosis we're going to talk about in the lichenoid category. But psoriasiform, it's kind of weak here, but you have epidermal hyperplasia, you have a little bit of spongiosis, and you have lichenoid inflammation causing necrotic keratinocytes and a dirty scale. This is pityriasis lichenoides, a little bit psoriasiform and a little bit lichenoid. Okay, but we'll cover that more in the next section. So let's go to interphase dermatitis now. Interphase dermatitis is kind of the umbrella term. What do we mean by interphase dermatitis? It means that lymphocytes are causing keratinocyte damage at the DEJ. They are destroying the DEJ, lymphocytes specifically, okay? And in the umbrella category of interphase, you might be on one end of the spectrum, which we will refer to as lichenoid, and that means you have lots of lymphocytes in your infiltrate obscuring the DEJ. Or you'll be on the other end of the spectrum of interphase, which is vacuolar, where you only maybe see a couple spaces that the lymphocytes are causing when they damage the DEJ, and there are less total lymphocytes. So very few, to the point where it might just be one lymphocyte causing damage to one keratinocyte, and you have to hunt really hard to see that this interface is present. How do we see damage? Well, damage is manifested as vacuolar alteration, which is like a white space, you know, near the keratinocyte. It's kind of, you're damaging that hemidesmosome connection of the keratinocyte to the basement membrane, and so it lifts off and creates a space. Or you see necrotic keratinocytes, cells that are actually damaged. When you have certain patterns, you have diseases in the spectrum that you can identify right away. Not all lichenoid dermatitis look the same, and some have special patterns that make you know you're looking at lichen planus or pityriasis lichenoides or lichen nitidis or MF or lichen striatus. However, if it's like a generic lichenoid inflammation where you're somewhere in between very dense lichenoid and somewhere in between vacuolar, then I like to think about the big three. The big three would be drug, viral, and collagen vascular, okay? So we're gonna go through this exercise. So on that far end of the spectrum with multiple lymphocytes, you're going to have the prototype, which is lichen planus. But lichen planus has some other features where from low power, every time you should be able to identify lichen planus. Not only is there a dense lichenoid band of lymphocytes, but you have compact orthokeratosis, which is pretty remarkable. If you think about how much inflammation is there, you would expect there to be more parakeratosis like we've seen in all the other inflammatory processes. But this is really remarkably orthokeratotic, meaning no nuclei retained in the cornified cells. I always think it must be something else if I see too much parakeratosis in lichen planus. You have wedge-shaped hypergranulosis, and then another very prominent feature is these pointy, reedy ridges. They're described in other places as sawtooth. But what I note is that they're just always pointy, and they might point in different directions. But it's one of the few conditions where you will see the reedy ridges of your epidermis become pointy, right? So here, what you can see is compact orthokeratosis. You'll see wedge-shaped hypergranulosis. So it's more than one layer thick, and in areas it's thicker than others. And then if you can trace here through your epidermis, you can see that your little reedy ridges have become very pointy. And then you have your dense lichenoid band of almost pure lymphocytes. You have a lot of melanophages. The melanophages are what give lichen planus the purple color. You've now shaken all the color out of these basal keratinocytes, and they've dropped into histiocytes that are causing light to shine through the epidermis, which kind of casts the white hue, to dermal brown, which always gives you a more blue or purple hue. The Wickham stria that you see are this epidermal hyperplasia that's pointy and irregular, giving you this lacy pattern that you see on the outside, okay? Here's an up-close picture, and then what you should see if you look really close is that this lichenoid inflammation just pushes up against the bottom, and you could see you have your necrotic keratinocytes, right? Colloid bodies, sabot bodies, all of those things, but it's damage to the DEJ, which is the point of lichenoid or interphase dermatitis. Here's another lichen planus, compact orthokeratosis, wedge-shaped hypergranulosis. Look at your pointy reedy. Your lichenoid inflammation may be really active, may be touching, may be getting old and fibrotic and moving down, but you'll see your necrotic cells if you look closely. But these are the features that make this diagnosis for you from low power. Here's another one, pointy reedy. You see nice outline of your pointy reedy here. Wedge-shaped hypergranulosis. Here your cornified layer is not as thick, but it doesn't matter. It's still orthokeratotic. Why is your DEJ splitting? Why do you sometimes get bullous LP? Well, it makes sense. If you damage enough of your hemidesmosomes with your lymphocytes, then in processing or in real life, you can easily shear off or weaken that connection between your epidermis to the point where it separates. All right, so what is this? Here you have massive epidermal hyperplasia, and this is actually shaped kind of like prurigo, where you have massive hyperkeratosis with this orthokeratotic change. You have hypergranulosis. There's this bulbous epidermal hyperplasia around the adnexal structures, which you can't really see, but take my word for it. This is what prurigo looks like. It's kind of exaggerated lichen simplex chronicus. But when you go in, what do you see? You see little, you see how it's a little pointy right there? You're starting to get pointy right there. This is hypertrophic lichen planus, which is essentially lichen planus changes transposed upon prurigo-like changes. Makes sense. That's what they look like clinically too. Is that LSC prurigo or is that lichen planus? It's very itchy. It's always rubbed. You can see the fibrosis because they kind of go together. Looking closely here, you can see a little necrotic cell. You can see a little necrotic cell here showing that you have an interphase dermatitis. And here you can see that even though you don't have much going on in the epidermis, what you do have is you have a lot of melanophages. And someone might tell you, oh, well, you just have PIPA here, but that's not all you have. Look in your epidermis, you have all these scattered necrotic keratinocytes. That shows you that there was lichenoid inflammation here, which makes sense because lichenoid inflammation makes you shake down more melanophages than other things like psoriasis or spongiotic dermatitis does. And that's why you end up with a darker blue, purple, brown pattern in the skin when it's resolving. And then the lichenoid inflammation also leaves behind a little bit of fibrosis, which, if you can appreciate here, you have more homogeneous collagen here. It's thicker. You see, you have solar elastosis, and it's pushing it down here. You don't see any solar elastosis here because the fibrosis is space occupying and it pushes it down. You see your reedy ridges? They're pointy. This is telling you that this is a regressed lichenoid process. Could have been lichen planus, could have been other things, but hard to say at that point. All right, so other things in the dense lichenoid category. Lichenitis is also dense, but how come we can always tell we're looking at lichenitis and not lichen planus? Well, one of the big differences is that you have a significant number of histiocytes mixed in with your lymphocytes in lichenitis, making the color look different. It's got more of a purple color than the black color of the nuclei of lymphocytes. And then you also have this epidermal cuffing, the ball and claw. So looking here, you see we have a lot of these larger cells with pinkish cytoplasm, not just lymphocytes. Lots of histiocytes mixed in, kind of lichenoid and granulomatous. And then you have your little ball and claw. See, up close, these are all your histiocytes, these big guys. A significant number mixed in with your lymphocytes. That's also significant because there's a differential for when you have lichenoid and granulomatous changes. Lichen striatus is also a dense lichenoid band, and it can look like lichen planus, but it often can look a lot like lichenitis, where it has lymphocytes and histiocytes, not necessarily epidermal cuffing. You can also have spongiosis, which spongiosis plus lichenoid inflammation leads to necrotic keratinocytes present in all levels of the epidermis, and not just at the DEJ like we saw with lichen planus. And then a more pathognomonic change is if you see a perieccrine infiltrate of lymphocytes. That all depends on if you're reading biopsies from academic centers or private practices. Where I used to read, it was mostly private practices, and it was very rare to have a punch biopsy. But if you get a punch biopsy and you see this, then you know you're probably looking at lichen striatus. So here's an example of a beautiful punch biopsy where we have lichenoid inflammation up here, and then we have a nice, dense perieccrine lymphocytic infiltrate down here. So we'll go in close to the epidermis. What you'll see is a lot of these pale cells again, a lot of histiocytes mixed in with these lymphocytes in a dense lichenoid pattern. Kind of looks like lichenitis. The differential for this granulomatous lymphocytic lichenoid change would be syphilis. So if I get a shave of this, I'm definitely going to check a T. pallidum immunostain or a spirochete stain to evaluate it. See, lichen striatus doesn't look like lichen planus. Look at lichen planus. You see how these individual lymphocytes are so dark, and you just see little black dots. But up close here, it's much more granulomatous. It's not always like this, but it can be. And there's your perieccrine lymphocytic infiltrate. Here's another example. This particular case of lichen striatus looks more like lichen planus. Now you've got your compact ortho and your hypergranulosis and your lichenoid band, which looks more lymphocytic. But then luckily you got a punch biopsy, and here you can see your perieccrine lymphocytic infiltrate. It's sort of a chameleon pattern, the lichen striatus. So erythema multiforme. Now we're going to get in our middle category, where we're moving away from a dense lichenoid band into somewhere in between. Just, you know, lots of lymphocytes that we can see, but not a dense band, and it's not like vacuolar where it's hard to see them at all. So your interface can be sparse to moderate. One feature that you'll see is you often see clumps of necrotic keratinocytes rather than individual little scattered ones. You'll see these clumps. They tend not to be confined to the DEJ. And then usually you don't see very many eosinophils, because if you think about it, what usually causes erythema multiforme? A herpes virus infection. So it's technically in the viral category. So you would not expect to see a lot of eosinophils. So here's an example. Here's your moderately dense interface. You have superficial perivascular lymphocytic inflammation. that then obscures the DEJ. See, all of your little white spaces are your vascular alteration. And you've got some necrotic keratinocytes at the DEJ, but you also have little clusters of necrotic cells above. That is pretty much a classic picture of erythema multiforme. It's relatively acute. You have a little bit of parakeratosis up here, but the rest of it is orthokeratotic. So that looks like it's been going on, under a couple of weeks. And you'll have melanophages right below the DEJ where you drop your pigment because you have an interface. Looking up closer, here is your interface with your vascular alteration and your necrotic keratinocytes down low. Here are some clumps of necrotics above. And then you see your pigment dropping right below. Your infiltrate should have not so many eosinophils. I would say the main differential for erythema multiforme would be a fixed drug eruption, because they also happen fairly acutely when you're biopsying them. And clinically, they can look similar also. You might see a targetoid, round, dusky lesion with fixed drug or erythema multiforme. So clinically, that's going to be on your differential, and histopathologically, it'll be on your differential. So how do I distinguish them? Well, this interface dermatitis can either have necrotic cells at the DEJ or scattered above, depending on how much spongiosis accompanies it. Generally, it is a acute on chronic process, assuming this is not the first time you're getting your fixed drug eruption. So you're going to see orthokeratosis in the cornified layer, meaning it's happening acutely. And then you're going to have numerous melanophages around this superficial perivascular infiltrate, not right below the DEJ, but down around the vessels. And that tells you that it's chronic, or it has been there longer than it should be, that the cornified layer is still unaffected. And your infiltrate, your dermatitis, is either superficial perivascular or superficial and deep perivascular, usually with eosinophils. So here's an example. You have an interface dermatitis with a lot of spongiosis. You see all this daylight between your keratinocytes. So now you've got lymphocytes exocytosing all over the place, and you've got necrotic cells high and low, but you also have eosinophils kind of scattered around. Here's your superficial perivascular infiltrate, and you could see melanophages all the way down here. Not just these. These drop right away. It's these that it takes longer to get to. And your cornified layer is acute. So this looks like it happened yesterday or sometime very recently. You had an interface with EOs. That tells you probably a drug, because that's mostly what happens is in that pattern, an interface dermatitis with EOs. And then you have this chronic pattern of melanophages there. The acute on chronic equals not only a drug, but probably a fixed drug. Here's another example of a fixed drug. This one doesn't have as much spongiosis. So now your interface is confined more to your DEJ. Here's your vascular alteration. Here's a necrotic keratinocyte. And here's your superficial perivascular infiltrate. You even have the melanophages down here, and then you have eosinophils. One thing that's also helpful that I didn't point out yet is that your necrotic cells tend to be scattered and individual. They tend not to be clumped in groups like they are in erythema multiforme. So the presence of eosinophils and this individual keratinocytes and the melanophages down deeper by the superficial plexus makes you favor a fixed drug over erythema multiforme. Here's another example of fixed drug. Remember your happy differential with your eosinophils and your spongiosis, except this is not just sponge, there's an interface. Once you have an interface with EOs, you're really thinking about a drug eruption. And then here's your pigment that drops right away, but you've also got pigment down around your superficial plexus, which takes a little bit longer to get there. Okay, so these are individual necrotic keratinocytes as opposed to little clumps of them, even though this almost looks like it's clumping, but all these eosinophils help you distinguish one from the other. Pityriasis lichenoides. So I mentioned in the last episode that the word pityriasis tends to refer to entities where you have a lot of exocytosis of lymphocytes. So Pityriasis lichenoides, like Pityriasis rosea, has a lot of exocytosis of lymphocytes. The main features, I can't tell you how many times I've gone over slides with residents and they want to make the diagnosis on extravasated erythrocytes, but so many things have extravasated erythrocytes. And so many times you have entities like this that don't have extravasated erythrocytes. So I would not use that as your number one feature. The most sensitive features when I'm looking at low power, how am I going to even think of pityriasis lichenoides? One, I'm going to note dirty scale. So what does dirty scale mean? It doesn't just mean there's parakeratosis. It means there's serum, parakeratosis, and inflammatory cells, okay? By inflammatory cells, I mean not only neutrophils, but sometimes you have lymphocytes, sometimes you have Langerhans cells. So different looking nuclei all sandwiched together in a wet, crusty scale, okay? And then you're gonna see prominent exocytosis of lymphocytes. So it's gonna be a little spongy and a little interphasey. And then you have necrotic keratinocytes in all layers of the epidermis. So we saw in LP, it really abuts the bottom of the epidermis, and our necrotic cells hang right there at the DEJ. But when you have a lot of exocytosis from the sponge, then the little lymphocytes can go up and kill keratinocytes kind of in the upper layers of the epidermis too. So if we look at that, so this is sort of a very, very subtle dirty scale, but you can see now in your parakeratosis, you don't only have those neutrophils, those PMNs, you have squished other kinds of cells. They're hard to identify. What are those? Probably Langerhans cells or something like that, kind of sandwiched in. You might see a speck of serum somewhere else. But then here you see how many lymphocytes you have shooting up in your interface. You do have vascular alteration at your DEJ, but you also have necrotic cells in all layers here. Your infiltrate should be predominantly lymphohistiocytic, not too many eosinophils, right? And that's how I arrive at a diagnosis of pityriasis lichenoides. Here's another example. Here's your dirty scale. You have parakeratosis. Here's a little glop of serum on the edge. You might have an inflammatory cell. Here's another inflammatory cell. It's messy. And then you have an interface where you have vascular alteration at your DEJ, but you have exocytosis of these lymphocytes. And look, you're getting necrotic keratinocytes in all layers of the epidermis, not just down at the DEJ. Here's another example. Here's your dirty scale. See all these different shaped cells sandwiched into your parakeratosis and little specks of serum? Here's your dirty scale. Here's your lymphocytes exocytosing upwards. This type of pattern makes people think about mycosis fungoides, and that's certainly evaluated a lot in these specimens. But look at your necrotic cells up high. Pityriasis lichenoides. Dirty scale, necrotic cells. Okay, so we already talked about secondary syphilis, but here's going to be another couple cases. Parakeratosis of neutrophils. We like to see neutrophils with infections. Infiltrate with plasma cells. There's nothing magical about plasma cells. They just tell you something's been going on for a long time. Remember, acute inflammation would be neutrophils, and then you develop antibodies, and you're going to start to see lymphocytes coming in, and histiocytes, and then if something hangs around a really long time and you've made specific antibodies, then you're going to have plasma cells. So secondary syphilis is a chronic inflammation. You'll have plasma cells. Anytime you have a tumor, you might see plasma cells because your body's been fighting it a long time. We mentioned before, there's a lichenoid and psoriasiform pattern, slender, elongated reedies. So here's parakeratosis. See here you have some neutrophils. They're not funny shaped. You're going to go in and you're going to see that pink cytoplasm with a multi-lobe nuclei. You have elongated, skinny reedy, and then you have an interface, right? Psoriasiform and lichenoid. And when you go in, you're going to be like, oh my goodness, look at all these plasma cells. I will say it doesn't always look like this. This is like a textbook case. There's certainly more subtle cases, but it's good to note. Another thing I wanted to point out is these elongated cells. These elongated cells, otherwise known as Histiocytes, because we're not sure what types of cells they are. Are they lymphocytes? Probably not. These types of cells called dermal dendritic cells. Anyway, in infectious processes, you tend to see them, be it a viral infection, bacterial infection, other types of infection. Those kind of clue me in that I'm looking at an infection. So in addition to psoriasiform lichenoid with plasma cells, the presence of the Histiocytes makes me suspicious. Here you can see your multi-lobe nucleus for your neutrophil. Okay. Now we're moving to the other end of the spectrum of interface, the very paucicellular vacuolar interface. This has been described as satellite cell necrosis. GVHD is kind of a classic presentation of a paucicellular interface. And that just means that one lone lymphocyte is attached to one lone necrotic keratinocyte. So here's an example of GVH, and here's one necrotic keratinocyte. You can't even see the lymphocyte. Or if you move through, you might see another necrotic keratinocyte, and you might just see one lymphocyte attached to it. Very subtle interface. Here's another one. See, little necrotic area here. This lymphocyte is probably causing a little bit of damage. It makes the DEJ a little bit fuzzy, but that's it. I had to zoom all the way into 40x to see this. Viral infections. So viral infections, remember I talked about the big three: drug, viral, collagen, vascular. So in most exanthems and enanthems, both viral, drug, you're going to see an interface dermatitis. You'll often see these elongated Histiocytes like we just mentioned. And then you may or may not have other special viral changes like herpes changes or this reticular degeneration change we're going to see in certain viral entities. So this pattern here, first thing I want you to note is that look at the DEJ. You see this vacuolar alteration, you're going to see necrotic keratinocytes too. You have an interface, and that interface is leading to this destructive pattern in these keratinocytes. What is happening to them? They're not only dying, you can see they're unhealthy. See, these have lost their nucleus. When you lose your nucleus, you're dead. And they're spreading apart. So edema is going in, and not only are they dying, they're spreading apart, and they're holding each other by these little wispy, thin strands that pull apart. That is called reticular degeneration or ballooning degeneration. Okay, those are the two names that refer to this pattern. Viral infections that have this pattern include Coxsackie virus, or when you see Hydroa vacciniforme with the EBV virus, this is the pattern that you will see. Reticular, that's referring to these little strands, or ballooning, that's referring to the splitting apart of this dying epidermis, but it starts with an interface. So here, look at these Histiocytes. I mean, it's a little bit crushed too, but you have all these very, very twisty cells at the DEJ. That is your interface. And now you have a different pattern. You do not have ballooning degeneration here. Now you have death of the epidermis in clumps, little clumps of cells. And if you look very closely at these clumps, you're going to see molding of the keratinocytes, margination of the chromatin, and multinucleation, which is sort of redundant when you're saying multinucleation. Okay. Good. You can't really see it. So what does margination of the chromatin mean? Well, normally if you look at a nucleus, the black color is even all the way through, and that chromatin material is what makes it black all the way through. Margination means that that chromatin moves to the edge of the cell, so you're going to start to see little nuclei that look like they have a dark outline and a paler center. That is a margination pattern that is very special and particular to a herpes virus infection. So these are all your multinucleated cells, but this is an older infection, so you've already lost your nuclei. But in some very focal areas, when you see that margination, then you know that this is a herpes virus infection. See, it does not have the ballooning degeneration pattern. And here is an interface dermatitis with just these elongated Histiocytes, superficial perivascular inflammation, mostly lymphocytic, not a lot of EOs, and this is just your run-of-the-mill viral exanthem. Okay, so the third one in our big three is a collagen vascular disease. So if we don't see a lot of eosinophils, and we do see increased mucin, we would think possibly of a collagen vascular disease. Now, it can be very vacuolar, meaning very few lymphocytes, or it could be dense and lichenoid. There's a range on this. The main entities we think about most are lupus and dermatomyositis. you tend to have a superficial and deep perivascular and periadnexal lymphocytic infiltrate. So periadnexal, the adnexal structures of the skin are the hair follicles, the sweat glands. You're going to see lymphocytic infiltrate surrounding those, as well as your blood vessels, and then the dermal mucin. And then DLE, which is chronic cutaneous lupus, you might see special features like a thickened basement membrane, follicular plugging, epidermal thinning, and hyperkeratosis, but you wouldn't necessarily see it in a non-chronic lesion. So here's an example of discoid lupus. Here you have hyperkeratosis, meaning you have too many cornified cells, right? You have a little thinning of your epidermis. That hyperkeratosis that goes down into the follicles, that's what gives you your follicular plugging. It's nothing more special than that going in the follicles. You have this dense perivascular and periadnexal lymphocytic pattern. So normally perivascular would just be around the superficial plexus and around the deep plexus. But here you can see the lymphocytic infiltrates going around the hair follicles. It's here going around some of the sweat glands, not all the sweat glands, but a lot of the sweat glands. Okay, and then you can see when we go in closer that we're going to have a little bit of thickening and smudging of the basement membrane. See this? This is your thickened basement membrane that you can appreciate even more with a PAS stain. And that's kind of your lupus band. And then here's your lymphocytic infiltrate, right? And you shouldn't have eosinophils in this infiltrate because it's not an allergic process. You also have dropout of pigment, right? Because you have an interface. Anything that damages the DEJ is going to cause pigment dropout. Here are your necrotic cells. You see how subtle your interface is? Just one little lymphocyte here and a necrotic cell. Some necrotic cells with no lymphocyte. Here's another lymphocyte. Very, very subtle. Here's another picture of DLE. Here's your hyperkeratosis. Here's your hyperkeratosis in your follicle. That's your follicular plug. Here's your thickened basement membrane, that pink material. Your interface. If you look closely, I'm sure you can see some necrotic keratinocytes. And then you'll have perifollicular inflammation. Okay, here's your follicles. And then if you look in here, look even deep down here, you can see the strands of blue mucin down deep. Now, any inflammatory process that gives you edema could give you superficial mucin. So viral exampum, drug eruption, bug bite, anything can give you superficial mucin. It's when you see mucin deep, that's when you think about a collagen vascular disease. Okay? And here's that picture that we showed last week of mucin. Here's another example, superficial and deep, perivascular, periadnexal pattern with lots of mucin. You're already thinking about lupus before you even decide if there's an interface. And in this particular case, you see a little bit of vacuolar change. It's a subtle interface, but not those chronic cutaneous changes like we saw with DLE. This is more of a tumid lupus type picture. So we just went over a lot of different interfaces, but the main things to remember are the big three. You know, you see an interface in the absence of any special characteristics. Make sure you've thought about viral, drug, and collagen vascular. First thing I look at, are there eosinophils? Yes, then you think about drug. No, you can't really ever take drug off the list, so you still have to think about it. But viral, collagen vascular, you have to think through. If you have elongated lymphs and just a superficial infiltrate, you might think of viral. Superficial and deep with mucin, you might think of collagen vascular disease. Or often you'll just get a rank order differential. Okay, and that's the end of our session. Thank you very much.